Good evening, everyone. We welcome you to the next, talk on the series of SIGs, which we have cerebral palsy. And we wanted to talk about the holistic, management of these patients. I think Asha stopped sharing the screen because she has a CV slide, actually. Share.
Okay.
Yeah. So we thought that we are going to have something holistic management should be there about these patients. So what we decided that two most important things are in a CP child in the management are the therapies, and the second is the orthopedic decision making, which I think pediatric neurologists are sort of not that much aware what the current things are, and we get delayed. So I thought that's why we thought that we should have the first one with the having the talking about the therapies, and second talking about the orthopedic decision making. So we have two esteemed speakers, Asha, who's a dear friend, and I think the first certified, American board certified neurodevelopment therapist in India, is running a private setup in Vedanta and in Mumbai, and has been training many people pan-India and obviously also globally. And can I have the next slide? And the other one is Dr. Matthew Varghese, who must be having the maximum experience of managing cerebral palsy patients in the world. And I'm sure about that and he has a zero wait list, and his OTs run till 1 a.m. And the amount of the effort and the empathy and the care he gives to his patients, I mean, I think he's a clinician come a psychologist come a surgeon, one in one piece with humanism all packed up. And I'm hats off to you, sir. He's head of the Department of Orthopedics, St. Stephen's Hospital, and it'll be wonderful having to hear from somebody who's the one person who's savior for all patients with cerebral palsy. So can we have Asha, please?
Sure. Let me just share my slide. Good evening to everybody, to all the dear experts, MK Nair, Dr. Biju, Matthew, sir.
One second, Asha, I'm so sorry. I forgot to introduce the experts. Sorry, actually we have two big stalwarts and experts. One is Dr. MKC, sir, who, as I was mentioning, is having a reverse aging, becoming younger by the date, and one of the few doctorates of science in India, and who has started neurodevelopmental, centers, the first CDC in Thiruvananthapuram, and the PG diploma program for that, and is working for child development, global delays, and also adolescent health, which is being pioneering. And we have so many tools, from Trivandrum, which he has been doing. So I'm really grateful to have him there. And yes, Biju Hamid, who's again a dear friend and who was heading the neuro rehabilitation in Gosh. Currently, he's on an assignment to establish neurosciences in the UAE. So we thought that, we'll have the expert, Dr. MKC, sir, who has devoted his entire life's experience on these children, and Dr. Biju Hamid, who's although Indian in origin, but he's in the high income setting. So he understands in the resource situation how it would be. So I thought when we are discussing what our speakers who are actually based in India and practicing in the India, so we can have the two experts making comments from both the sides. I thought that would be very rich. And the moderator is Dr. Deeptanshu Das, who will be taking on through the Q&A and the discussion. And he is also the secretary of this SIG. Deeptanshu, you want to say something? Because Mahesh didn't start, so we didn't go by protocol, so I forgot actually. Yeah.
I think today's discussion is very important, and let us go forward with it, and we'll discuss further.
Thank you.
Should I start, Shefali?
Yeah.
So I have half an hour, right, Shefali?
Right.
Yeah. Thank you so much. It's a great evening. And what I'm going to speak today as a pediatric therapist is changing face of cerebral palsy, a therapist perspective. I think so we really need to understand what's the burden of disability. And if you really look at what our situations is, the last national sample survey was done in 2011, where they talked about 44% as locomotor disability. The prevalence of disability was 2.3% in rural areas and around 2% in urban areas. If you look at our Indian statistics on incidence, basically it says that it is 3.8% of the population, nearly 15 to 20% are physically disabled children and are affected by cerebral palsy, and our incidence is 3 into thousands. Now, some practice multidisciplinary system and interdisciplinary system. I think so we really need to look at this. See, what are the differences here? Multidisciplinary system is like a process where professionals from different discipline works independent versus, and basically they all address a common problem, versus all of us form an interdisciplinary team and they all work together, and that's most important. They do address a common problem, yet continue to do so largely from the perspective and disciplines perspectives. And it's very, very important to understand that. As a therapist for 25 years, every parent who's diagnosed by you all, they come to us and the first question they ask me, will my child walk? And how severe it is. And it's a very difficult question to answer both on compassion and empathy and on also evidence. So I think so for that, you really need to understand what is ICF, what are the classification systems, and what are the Ontario motor growth curves. Let's understand them. So we have 5 classification systems. Gross motor functional classification system talks about mobility. Mini-MAC and MAC talks about the hands. CFCS talks about communication. EDAC, it talks about eating and swallowing, and VFCS talks about the visual functional classification systems. Now let's talk about the first one, which is GMFCS. And what GMFCS, basically, it is defined at different groups. Never ever give them a GMFCS classification before 2nd birthday. Please divide them into these groups because that's how they've segregated it. 2nd to 4th birthday, 4th to 6th birthday, 6th to 12th birthday, and 12th to 18th birthday. What is it in gist of understanding the classification? Level 1 is what we are, walks without limitation. Level 2 is there are very, very minimal limitations. Level 3 is it walks with support. Level 4, they require powered mobility, and level 5 are fully dependent on children who are requiring a lot of help. Now, this is very important to understand. I always stick these pictures in my clinic. It helps parents really perceive. Now, look, this is 6 to 12. And this is 12 to 18, and we'll discuss why these 2 ages are very important. Level 1 is throughout the same. Level 2, they're doing pretty well and maybe require somewhere and uneven surfaces will require crutches to walk. But if you really look at level 3, they walk with walker for a time up 6 years, and then they get into basically a wheelchair. But eventually they need a power wheelchair if they're really accessing society and participation. Level 4 may take few steps within the house, but eventually as they grow old, they will require a mobility. Level 5 are totally dependent. And I think so this is very important as we go further. Another thing I think so Matthew Verghese sir will really speak about, but I think so everyone needs to understand that in cases of GMFCS 4 and 5, the hip displacements are very, very high. And remember, hip displacement is not related to a motor type, but it's related to the GMFCS classification. As therapist, I need to understand that it's extremely important for me and for all the team that we are, that it's appropriate to refer it out to an orthopedic surgeon. And we should know that as classification increase, the chances of hip subluxations are very high. And so with our kids have 90% of them have asymmetry, and the chances with kids with hemiplegia, quadriplegia, or asymmetrical diplegia can have scoliosis. Hence, hip surveillance and spine surveillance is the need of the hour. And I think so we all need to understand and need to be on the same page. If I have to kind of get all the 3 classifications together, MAC is manual ability classification systems for hand, and CFCS is communication functional classification systems. Level 1 is totally independent. Now look at level 2. It works with minimal limitations. All they can handle all their objects, but basically they will have less speed and dexterity. Here, when they're communication means they can either speak or communicate with gestures. They can receive with familiar and unfamiliar partners, but may need extra time. Level 3 will always need support. For hand, they will need many adaptations. And here they can only basically receive or communicate to familiar people. Very difficult to communicate to unfamiliar partners. Self-mobility is very limited in both level 4s and level 5s. Even for MAC, they're very, very dependent. And specifically, it's very important to understand that if you're doing any kind of surgical interventions for kids with GMFCS4, realize that if their hands are okay to pick up an adaptive equipment and communication, they can very rarely do it with unfamiliar people. Only with familiar people is what it is understood. Now, what is VFCS? It is about function with the vision. Level 1 and level 2 are pretty good. Level 3 will need a lot of adaptations. They may need blacks and whites. They may need better screens. They may need large fonts. And these are kids between 3, 4, and 5 who definitely be having either corticovisual impairment or delayed visual maturation. 4 is very, very minimal and 5 just do not function. There is Christine Roman's corticovisual staging, and that's what we basically use. And the last classification is eating and drinking. There are 2 levels of it. One is what is the level and what is the level of assistance. Level 1 is like all of us, that they can drink. Level 2 has very difficult, very little efficiency that is lacking. Level 3, level 4, and level 5, we need to understand that these are guys who can definitely have aspiration pneumonias. You have to really look at their swallowing, and mostly level 4 and 5 may require PEG. We also need to understand about assistance. Are they independent? They require assistance, or they're totally dependent. Level 4 and 5 will always require totally dependent and require a lot of help. This is the cross motor curve, of course, and it's really nice. Look at this, what he says, when they plot a graph of GMFM 66, which is an outcome measure versus the age across the y-axis. 6 to 12 is the most critical age. Level 1 and level 2, as we saw, are really doing well, but level 3, level 4, and level 5 will decline. The decline starts at 6 and really is very prominent by 12. And you need to understand, as therapists and all of us, we need to have really, really well goal setting. And that is important for us to realize that he does not fall, because any kid will never change the GMFCS, but a level 3 child can become a level 4 if not taken or not in therapy. The double whammy about neuroplasticity, this was talked about by Karen Pape, a pediatric neurologist from Canada. She's written a lovely book, A Child Can Run But Cannot Walk. She also says that 6 to 12 is where the neuroplasticity is a little less. And hence, I think, so understanding this, it's very important, and have proper goal settings. Another point we all need to understand, when I say GMFCS levels don't change, whether you do therapy or you do surgical interventions, the GMFCS level will not change. What it improves is the capacities, the participation, the quality of movement. And hence, it's just a classification system. I like this chart that I made. Parents' first question, and how do you respond? How bad it is? GMFCS. Will our child walk? The motor growth curves will prognosticate. How do we know it's working? Please use outcome measures, pre and post, and you will understand through your timelines how the treatment matters. This is very important. A level 1 child will sit by 1 year, walk by 2 years. Level 2 sits by 2 years and walks by 4 years. A level 3 who sits without support by 4 years will walk by 8 years. Understand this when you plan your goals. Level 4 and level 5 are totally dependent. A nice chart between the ages of 2 and 6. Can your child walk, climb steps independently? If it is yes, he's level 1. If he needs support, he's level 2. But for level 3 and level 4, if he requires assistance, he's 3. If he not only requires assistance and wheel device, is level 4. This is very easy to understand, because then it tells your parents where that child is. ICF tells you about participation, tells you about personal strengths and environmental factors. And I think so, we really as therapists and the team needs to understand, can we move from clinics to community? Why? Because the best outcomes of people with disabilities results when the needs are aligned and how they function in society. Hence, SMART goals are very important. Realistic goals are important, and look where they perform. I always believe the child that I see in the NICU is going to be an adolescent and an aging child with cerebral palsy. Hence, keep the big picture and move on. Neuro rehab in 2023, we live in a great time of change. Lots of new developments are happening in neuroplasticity. Also, there is a huge research that is helping us understand the skeletal muscle and the changes that it's doing. And I think so if you integrate these points together, it's going to help us have you more understand. Let's understand what is therapy into practice. There are many therapies available. It's a holistic approach. NDT, SI, constrained induced. Context-based is a new thing that is coming. Strength training, motor learning, functional electrical stimulation, myofascial release, craniosacral, suit therapy, splinting, casting, and all the adjuncts. Let's understand one by one. Early intervention, according to me, is the need of the hour. When do we begin? Look, this is a plasticity at 1 month. Sorry, at newborn, 1 month, 0. The more you salvage this, the more better it is. This is so important, because this is how you support your families during the critical year. What do? Position them, do chest BTs, also do some therapy when they are stable and medically stable. Teach them prone positions, and if they have refluxes, please give them pillows so they do not have projectile vomits. Now, going back, does therapy influence neuroplasticity? Absolutely. What you teach. keeping this alignment together, working on function is definitely going to really help you augment that neuroplasticity. It was amazing for me to really look at PubMed citations. There are only 1,300 articles on neuro rehab, but there are 29,000 articles that talks about neuroplasticity in pediatrics. And I think so it's a big game changer. What is about motor things? These are trying to tell you that I work on weight bearing, I work for gait, I can use suspension, I'm working on control, proximal control. We need to work for function where that child is. And weight bearing, I think so Dr. Matthew sir will talk about how important it is in every children that we need. Don't forget the sensory systems. Look at their visual, vestibular, somatosensory systems, because that is what is a critical part of balance. And this is working through sitting on the swing, outside the swing, and also using the ball to reach. This basically helps them if they have sensory-based motor function. Constraint-induced therapy, there are many papers. What do you do is really basically restrain the child, structure the practice, and basically just pay attention. It's usually used in kids with hemiplegia, that we do not really create lots of compensations. It helps motor learning. Lots of kids, you have to realize as therapists that once there is a deformity or contracture, me as a therapist cannot help a child. And that's where I require an orthopedic surgeon. He may decide what is required, Botox surgery, depending on the age, but you need to start working on their control when there is plaster. We also do treadmill training. We always use a harness. We'll only use treadmills when there is no deformity and the speed is 1.5 and it really helps. Sometimes I use a walker with it. But then there is this new thing, which is context therapy. It's really, really useful. It's in BMCN. It's a lovely article. It's a very new article, 2018. They basically focused on preschool kids. GMFCS 4 and 5, guys, remember, there is a time they're not going to show improvement. But what can you do? What you really can do is this. Change the environment, focus on remediation of the abilities that are there. And hence, it's going to make that child as independent as possible, rather than just doing all these fancy activities that's not going to help. There is a lot that is happening. And if you continue to do that, it's going to be so much better for a parent and the professionals that treat. Parasuit, basically, these are garments. These are very useful. See, it's expensive, this spider cage, but it's helpful when kids are operated and you get strength training for individual muscles. Electrical stimulation is a very fancy thing. I don't use it myself. I've just borrowed this slide from a great friend. It basically helps motor learning. These are these electrodes, and they basically give you strength. You can use it from the trunk, or you can use it for wrist extensors. They say that it helps, but there is not great evidence. This is how they do it in treatment when the child is walking, and that helps. And this is Walkade, where it's a very expensive $1,000 machine. It's used for kids with hemiplegia, and that gives you dorsiflexion in gait. Remember, do not ever forget that home, community, and carryover. My God, to understand remember, I think the biggest take-home message from my lecture is my parent is the #1 therapist. And if I do not design strategies for home, school, and community where the child is going, there is going to be no carryover of my performance. And it's extremely important to decide which are the 2 or 3 things that the child needs to do that improves their strength and endurance in a community setting. You can use gardens, you can use swimming pool, you can use school, you can use friends, but doing those home programs is very important. One word of caution out here: when you have kids with GMFCS 4 and 5, please, please never forget, start very early, do chest PTs, and continue to keep away from pneumonias and work on cardiorespiratory strength and fitness. It's very important. Every mother needs to know how to get the cough off, how to do chest PT when you're real, because there are great chances of aspiration pneumonias. Another very important thing before I go to another point is, when do you stop and abandon therapy? Remember, when you're transitioning from one stage to the other, specifically when you're going from 12 to 18 and from 18 to adolescence and then into adulthood, there are no longer, when do you abandon where there is no functional gain, the clients up. Remember, there should be no burnt out, okay? The kids get so burnt out. That's why therapy needs to be minimized. And I think so. I never call people more than twice or thrice. Your therapy really needs to impact. Calling them every day is worse, but there is somebody who's coming from outside. Please do burst intervention. That means I work for a month and just pick 4 days up and kind of do therapy and get some goals set up. Always pay attention to psychological issues. Very, very important. Remember another take-home message that therapy is a limited resource and it can't just go on. You need to know if there's an adult, I'll try to go, say, do swimming, do dancing, go to gyms, work out, just take care of these things, send me the videos. Always remember on horizon, these new things are coming. Robot-assisted therapy, virtual reality, technology, vibration, and brain-computer interface. Not much evidence is there, but let's understand. Robotic therapy is really useful. They have an RMO swing that they use. There are 2 papers in 2018. There are many, but I just quoted the best ones out here. And they are saying that it really helps in improving the quality performance. It motivates the child. It's fun for the child. And it doesn't seem like therapy. There were studies that were done, and I think so it really works well. If you have a child with hemiplegia, the most important thing that you need to know is you should be cognitively driven and you should understand what is required, and the child needs to have less of motor planning issues. Then if you look at a meta-analysis was done in on virtual reality, I like the Wi-Fi stuff. If parents have Wi-Fi, I really tell them these are 3 games that you please do. It gives them the flexibility, it motivates them. The parent can be a partner with him. You can get your standings, like this is great. I do a lot of that stuff. If I can get standing, I get my dynamic mobility, and I can kind of use this if there are hands that are involved. And it's see how much you can challenge and how better you can get. This is the most dearest part to my heart, and we're really missing transitional care experts. You know, a field of rehab that did not exist a few decades ago, but it needs a lot of innovation. Today, my kids are 21 and 25, really don't know whom to send them for epilepsy. There are orthopedic surgeons who need to look at their back aches, their knee aches, their shoulder aches, if there are kids with dystonic cerebral palsy. Always remember the thought of the day is that adolescence of 2030 is a 3-year-old when I started treating him, and we have to prepare, and hence I said a lifespan approach is very important. What I want to convey that when you really deal with these teenagers and adolescents, yes, there is therapy, but look, don't forget the 5 Fs: function, fitness, feature, family, friends, and fun. They need to really be a very important part. Don't do basic therapies. Look for skills, functional skills. See how they access the world. I have a girl who accesses using YouTube, and she's a lovely cook. I mean, that's what is very important. What is their contribution? How much can they be educated enough to take care of themselves? And mind and spirit, always see that they're pepped up, because these are kids who have a lot of problems with their mental selves and their mental well-being and the caregiver's mental well-being. And physical health is very important. Fitness. Why do I say this? I like the WHO definition. So when you're talking about parent dependency, independence, and partly dependent, what does it talk about? Physical means ADLs and mobility. Social is inclusion, community, and integration. Financial is it token or actual? This basically through the lifespan is a lovely definition of independence. And I think so we really need to understand this when we're looking at a lifespan approach. I'm going to just quote 2 papers about physical activity in adolescents and young children with cerebral palsy. 65% were physically active, but only 56 did exercises more than once a week. Fitness is very important. Remember, kids who are aging will also have problems like our aging, blood pressures, diabetes, cardiovascular. Hence, fitness is going to be a key role. You can use dancing, you can use whatever you want, but you need to see that these exercises are done. There's a lovely article in DMCN, and it basically says that there is a decline in gross motor capacities in adolescents. What really stood out, and the more I read, is whatever I do as a therapist, I give them elbow crutches and I give them cord canes. Remember, pain is the #1 problem. People who have used GMFCS3s, who have used walkers for a long time, or used cord canes for a long time, come back and then their postures are not good. They come back to me. And I'm not an adult orthopedic therapist. I really need to get some musculoskeletal expert to say, pain is the highest problem that we are facing in shoulders, backs, and knees. And I think so we also, as our therapists, when we start really working early, need to pay attention of what is allowed and what is not allowed. So I feel strengthening is a critical part. Aqua swimming is a critical part, in dance. These kind of stuffs will work. A clinic-based therapy may not work for adolescents. Lastly, when I kind of sum it up in a few slides, remember, that's what I said. If I have a 6-year-old sitting like this, and if I don't improve her posture, I'm going to add so many deformities and not prevent deformities. I think so sitting is a critical part, because they do a lot of sitting, whether it's a wheelchair, whether it is a crammed, whether it's a sitting in school. We may not have these fancy stuffs abroad, but we can easily, this is my rural camps that I do, and this is how I've done a cutout versus a plastic chair versus a bench. This can be easily done. And I think so. This starts way early when the child is few months old. And this continues through the lifespan. This is something that will prevent hips and spine surveillance. It will help them and prevent any kind of secondary deformities that can happen. Now, there are lots of things like speos, teratogs, DMOs, hip helpers. They may help some kids. There's no really great evidence, but it really helps. So let's understand speos is stabilizing input pressure orthosis. It's great for parents. If there is a lot of involuntary movements, if they have sensory issues, it gives you lots of probe and probe. Basically, it's not very supportive, but it really helps your trunk control. It could be a nice way to set, it may not help for therapy, but it's a nice way to put this on, send him to school where he can sit well. The best I like when kids are at risk, I give abduction pillows. This is too fancy for our country, but some kids can afford it, and that's a squash brace, basically, to take care of the hips. Aqua therapy helps, but this is an adjunct. These are hip helpers. You can have walking shots and connect them together. If this is an indigenously made thing, DMOs are great in London, very expensive. But basically, if you don't have DMOs or teratogs or speos, take a Lycra swimsuit and use with it. It gives you some amount of stability, and that helps parents to carry them, to transfer them, and to get them to school. Standing is very, this is an abduction pillow. Standers, static versus dynamic standers. I feel there is a pretty good evidence. Static standers or dynamic standers are for someone who's got good control. Static standers basically gives me all the stability. It helps me with kids who are at risk of subluxation, helps my bone health, and it gives them verticality. So it's very important to do standing. You can make different standards, but see that parents use these standards. You can make a wooden plank and also make a child stand, but standing is an equal important part. Teratogs are too expensive, not for our country at all. Very cumbersome donning them, and specifically these straps that you see. If they're not done well, you will always have internal rotation. So I think so this is to be very judiciously used. People get some stuff from the West, but it may not really work in our country. Splinting is effective. There's not much evidence, but at least it maintains the range. It helps the child not understand which are abnormal movements, and using it for few hours. These are all dynamic splinting. They are all made by Lycra, and Benic is basically made by neoprene. These are pity wraps, and it really helps because these are not firm and they can allow a lot of work to be done. Adaptive and adjuncts, I love. I make them by thermocol and all. It's not expensive. This is what I really like. You get them on Amazon. This is like a plate that sticks, so it doesn't have to bother. I mean, making these spoons and doing this makes life easy for someone who's really struggling, and for parents also. And it can require assistance. This is a communication box. There's so many stuff that are available in the market, and it can help child communicate who's not basically speaking. This is technology. This is a ball where she can really do what she needs, and she can answer them. These are iPads, and this is a very fancy hazel eye way. But these are things that can really help a child to at least say yes, no, and basically at least tell whether he's in pain, has somebody hurt him. Communication is the most integral part, and it needs to be incorporated at year one. But technology has made life very easy. We are almost done. As I kind of summarize, remember that neuroplasticity provides significant hope for the future of persons with cerebral palsy. Current and future therapeutic interventions needs to capitalize on this potential. There are potential problems and roadblocks for neural plasticity cannot be accessed, maximized if there are mechanical problems like contractures and deformity, which we will hear in the next lecture. Remember that musculoskeletal plasticity and neuroplasticity are interwoven. If you really need to positively manipulate, early intensive interventions that influence both neural and muscle plasticity should become and prevent negative changes. Continued research is needed to determine possible treatments for the negative changes in skeletal muscle in patients with cerebral palsy. The current evidence that you really look at doesn't really show good. I mean, I'm not saying that every child may not benefit, but overall, it does not show medical interventions such as Botox and some muscle lengthening procedures may contribute to negative long-term changes, and that has to be very judiciously done. So in conclusion, as rehabilitation professionals, we need to speak with one voice. Early intervention and environmental modifications can prolong safe, independent living for children or adults with disability. Health risk monitoring of children or adults with chronic disability is a critical across the lifespan. We really need to prevent secondary deformities, contractures, really need to nip them early, specifically the hips and the spines and the shoulders in kids with dystonic cerebral palsies. Education and screening that promotes healthy lifestyles is a must. Yet today, if you ask me as a therapist after 25 years, and if you even go to the APTA guidelines, how much is great therapy? What is the efficacy of treatment still remains a dilemma, but it has been said that there should be no burnt out. Mother is your therapist, hence max therapy should not be more than 3 hours a week, or it should be just 2 hours a week. And I think so it's extremely important to speak on that. As I end my lecture and thank everybody, I thank all my mentors, my colleagues from the therapy domain, and to all the families and the children I've been privileged to work with. I always feel they've taught me to seek for the highest, aim at the highest, and reach at the highest. Thank you so much, where I end my lecture.
Thank you, Asha, for this amazing talk. We request Dr. Matthews to start sharing the screen, and then Diptanshu, you can ask both the experts to speak up after both the sessions, right? And the Q&A.
Right. Yeah, Dr. NTC Nair, sir.
Beta, after both the talks, we can have the discussion.
Okay, so let's go on to Dr. Varghese, and sir, would you like to share your screen?
Yeah, I'm just trying to do that. Apologies.
First, open your presentation, put it on slideshow mode.
Sorry, I've opened my presentation. Is there?
Put it on slide.
You'll have to click on the share screen button.
The
Share
green one.
screen.
Yeah, the green icon.
Can you see something?
Yes. Just make it full screen, sir.
Just give me a minute.
The 8th option of your menu bar, slideshow. Click on that. Yeah.
Yeah, thank you so much. First of all, thank you so much for giving me this opportunity of speaking. And I think I must thank Dr. Asha for speaking my mind out on what I tell patients. She's just voiced it so clearly. She doesn't want parents and children with cerebral palsy spending their days and weeks and months into clinics and therapists and physiotherapy and surgical interventions on everything. So nice of you to highlight that flag, Asha. Thank you so much.
Thank you so much, sir.
I really appreciate that thought, because so often I'm telling my patients, please don't bring your child to the hospital, take the child to a picnic. Don't bring the child will be happier in a happy home. That is what is most important. The orthopedic part is a little tricky, because the orthopedic assessment takes a long time. And the orthopedic assessment in a clinic is an artificial assessment. So often I have parents of children with cerebral palsy telling me, Dr. Saab, he's walking like this in front of you. He's never walking like this at home. So remember, your clinic is an artificial environment. So the first warning that I tell patients, parents or caregivers is, please, if a surgeon has told you a surgical procedure is required, review it again in the next visit. And when I train my postgraduates, I tell the same thing. Please don't be judgmental on a surgical procedure on first visit. The second visit, the child might be more comfortable with you, may realize this doctor, this white coat is not going to give me an injection. He may be more comfortable and be more normal with you. And therefore, your examination may be far better, and the result of that examination will help you decide on how to deal with this child's problem and how we can improve this child's life and these caregivers and their guardians and their parents' life a little better in their lifetime. That's what we have to do as physicians and caregivers. And I keep emphasizing that to my postgraduates, to wherever and whenever I go for training, I do that. It's a very long lecture. It's not easy for me to do justice. So, excuse me if I overshoot the time. You can stop me, don't worry. But address the issues in question answer. Wherever I reach, I'll stop and we'll deal with it in the question answer session. I thought I'll get time to address the issues and, edit this lecture. There's actually a 3-hour lecture that I give to postgraduates, but I've edited it to some extent, but I have not been able to do justice to it. Now, the decision making in surgery, in orthopedic surgery, I didn't mean in operation surgery, but in decision making in orthopedic surgery department, first of all, has to be in consultation with the neurologist, has to be in consultation with the therapist, has to be in consultation with the pediatrician. It's a teamwork. I start this lecture with the understanding that you're not working alone. You have a therapist out there whom you trust. You have an orthotist out there whom you trust. You have a neurologist out there whom you trust, and you double check at different phases of the child when the child is brought to you, whether the child is in infancy or in childhood or in middle childhood or in adulthood. Whatever be the age group in which the child is brought, you need to be clear what is it that the parent is wanting. And as Asha mentioned so nicely, all that the parents want, when will my child walk? That's what they're interested in. And I can understand their concern. And their concern is understandable because they are worried. Today they are alive. Tomorrow, when they are no more, what will happen to their child? Will the child be able to go to the toilet? Will the child be able to do activities of daily living? Functioning at home, just at home, is their main worry. So we must understand that their goal is walking. But again, Asha highlighted the fact that the key goal in dealing with a cerebral palsy child is communication, not walking. Communication. And for communication, what is key is education. And for education, how do you deal with that education with a child who has a difficulty in speech, who has difficulty in hearing, who has a difficulty in writing? How do you manage written speech, spoken speech, thought speech? How do you manage all that? And how do you get what thought speech is there in the child's mind outside for you to communicate? Those are key goals that you have to keep in mind. So in infancy, first goal would be to make sure the diagnosis is right. Today also I had a child. In fact, I made a mistake. I thought the child has the cerebral palsy. The child had a syringomyelia. So first step is to make sure that the child's diagnosis is right. In infancy, get the right diagnosis, get the right therapist to do the guidance for the right therapy. And initially, in phases, you have basically posturing that needs to be taken care of. Subsequently, 18 months to 5 years, the child is rapidly evolving. The brain, which has come up with a formatted brain, is now absorbing information and is actually learning so many things, and the child is going through the phases of learning. Earlier, many years back, 30 years back, 25 years back, even in early childhood, we would advise surgery. Things have changed now. Again, we look at the GMFCS score, age-based GMFCS score. We know that many of these children who are going to be independent, they are going to be walkers by 4 or 5 years. So we want to see the potential of this child, how the child is beginning to stand, how the child is beginning to walk before we decide on a surgical intervention. So don't jump to a surgical intervention just because the child has come to you with an equinus. You don't rush to do an equinus surgery. Don't do that. We let the child observe, be observed over a period of time to come to a conclusion. As they grow closer to the school, again, the parents are worried about ADL. Parents are worried about their child is not going to school. How do you decide on the goal? So goal setting has to be a combined activity with the parents, with the guardians, and with the therapist and the pediatrician and the neurologist. And so it's a teamwork that is important. We need to look at how will the child, if it is sent to a school, how will the child perform as an inclusive learner in a school with other children there. And as they grow into adolescence, one of the biggest challenges is because they are not able to move, they start gaining weight. They really have very high BMIs, many of them, and that compounds the surgical problems that go with it, and therefore there is an issue. In examination, for the orthopedic surgeon, the examination has to be clearly divided into two parts: a static evaluation and a dynamic evaluation. Static evaluation, looking at contractures. Are there any contractures in the joint? Are there any joints which are non-stretchable? Sometimes it is very difficult to differentiate between a static contracture and a dynamic spasm that is there. The only way of differentiating this would be at the time of giving anesthesia. So many times I tell the parents, look here, this equinus looks to be a severe static equinus. I may need to do something more than a myofascial release. However, I'll make a final decision when I give anesthesia to the child, and then I know that this was truly dynamic and this is truly static. So those assessments, so it's a continuous process from the clinic to the theater also. Even after anesthesia, you're continuously dynamically evaluating. I need to share with the parents that this is what I am planning, this is what I am looking at. So the static mode examination, looking at the posture of the child. What is the static posturing of the child? Is the child having the classic flexed hip, flexed knee, equinus ankle with a flexed elbow, palmar flexed wrist, pronated forearm posturing? Or is it any other unusual posturing? Or is it a dystonic posturing that is there? And is there a thetoid component? When it comes to surgery, we have to be very clear. The dystonics and the athetoid components do not perform as well after surgical releases and surgical procedures of tendon transfer and other procedures. The reason is, in the brain, wherever you have these athetoid components or the dystonic component, they may migrate from one joint to the other. So what posturing was there pre-op may change to a different posturing post-op. So you have to be very careful and warn the parents on that. In the static mode, for example, in the child sitting, we look at the child sitting. Most commonly, we see W sitting as a common sitting. So this parents might come to you, and an orthopedic surgeon, the moment there is a history of W sitting, we are worried. W sitting indicates there is an adductor spasm. W sitting indicates there is probably excessive anteversion of the hip joint. An adducted hip is a hip which is vulnerable for dislocation. So we are worried about that. Then the usual diagnosis that is confirmed is the thumb in palm. The thumb in palm, I'll talk about it a little later, which you look at that. And then you look at the dynamic mode of examination. In the dynamic mode of examination, we see how the child, when the child is moving from the lying down to the sitting position, from the sitting position to the kneeling position, and from the kneeling position to the standing position. Quite often I have seen orthopedic surgeons, they do not look at the kneeling position very significantly. And kneeling position can give you very many more informations than what you imagine it to be. The reason is, if you remember your middle school physics, the middle school physics teacher would have taught you that your balance depends on your height of your center of gravity. Higher the center of gravity, greater is your instability. Lower the center of gravity, more stable are you. Therefore, a child may have muscle power, may have spasm, may have no deformity, yet may have very poor balance. And poor balance will lead to poor standing ability. So if you have a child with contracture and has no balance, doing surgery on this child will not get the child to stand and walk. So this is something that we have to see. What is the goal of doing surgery in that position? Is the child having a standing balance? No. So then the child cannot be expected to walk. However, the child may have kneeling balance. Kneeling balance, the center of gravity is a little lower. If the center of gravity is lower, you know that this child has a potential, possibly can be a supported standard later on, but needed to work on improving this kneeling balance and work on that. So it's a surgeon's role to assess the balance ability before you do anything. So the balance ability can also be compromised by the posturing. The posturing is it's fascinating. In the lower limbs, there are three key joints that you need to look at. They are related to each other, they are linked to each other. They are like liver arms that are linked liver arms. So if you look at the hip, knee, and ankle, each of them influence the other joint. And therefore, the muscles that cross these joints, particularly the two joint muscles, these are the ones which are troublesome muscles. And when a surgeon is advising surgery in cerebral palsy, most of the time the surgeon is dealing with two joint muscles. So here is the patient. It's a model that I have where you have a patient who has got a flexion deformity of the hip. Because this is an energy intensive position, he cannot maintain this position. So what does he do? He will flex his knee, and when he flexes his knee, because his ankle gastrocnemius is usually a tight muscle, he will adopt this posture of hip flex, knee flex, ankle off the ground. May not be equinus. Ankle off the ground may be different from equinus. So we need to be clear on this. If a child has come to you with this posturing and do an ankle myofascial release, that is a disaster for this child. So decision making in this child has to be based on where is the primary problem. Is the primary problem the ankle? No. Is the primary problem the knee? No. The primary problem is the hip. But there is a secondary lever arm effect on the knee and on the ankle, and therefore those are secondary issues. It's a surgeon's job to differentiate between these primary and the secondary. And we need to understand as the hip flexion worsens, the knee flexion worsens, and you need to look at it from that perspective. Let's look at the other side. That's a spasticity of the knee joint with flexion deformity of the knee. If pure flexion with other joints unaffected, this will be the posture. And this posture is again energy intensive. To compensate for the energy coverage, the energy consumption, the patient will again adopt the same posture. He can do this posturing or that posturing, whichever way, he'll adopt a position where he will again use this jump positioning, hip flex, knee flex, ankle in off the ground. So this is the importance of understanding knee flexion can lead to hip flexion and heel off the ground. So this assessment is again important. Again, look at a child with equinus with no problem in the knee and the hip. When he's standing with equinus, his center of gravity is elevated. When his center of gravity is elevated, his demands on the balance muscles becomes much more. So what does he do? He intuitively lowers his center of gravity. And how does he lower his center of gravity? By flexing his knee and his hip. Again, the same thing. Just look at the three situations. Each of them, the primary problem is a different joint. And each of them present with the identical posturing of hip flex, knee flex, and ankle in off the with the heel off the ground. It's fascinating. So the surgeon's job is to decide where is the primary problem and deal with that. By and large, what we have seen is a child will come to you with an equinus posturing. That is it. But he is really off the ground and he is walking like this. Then you look at the age of the child. The goal in managing these children, we try to avoid surgery before they are 5 years or so. So until then, we manage with the help of therapists, with the help of ankle foot orthosis. That is the usual posturing that we. So we give an ankle foot orthosis so that the child does not develop a contracture in the gastrocnemius. Remember, gastrocnemius has also another name, triceps surae. Why is it triceps surae? Because gastrocnemius, two heads, and the soleus. Now, triceps surae has soleus as a component there, and soleus is a very important muscle. Earlier, we would regularly do TA lengthening, tendo-Achilles lengthening, which would lengthen the gastrocnemiae plus the soleus muscle together, which would lead to a disastrous situation for the child with cerebral palsy. Why? Because that will cause the postural muscle of soleus to be lengthened. So the current advice that we do by and large tell postgraduates is when we're teaching them, do not do a tendo-Achilles lengthening as far as possible in a child with cerebral palsy. Manage with a myofascial release of only the gastrocnemius. Remember what I said. Two joint muscles are trouble muscles in cerebral palsy, which is soleus is a single joint muscle spanning only the ankle joint from the tibia to the calcaneum, whereas the gastrocnemius is the two joint muscle spanning the knee joint and the calcaneum. So knee and ankle both are spanned. Gastrocnemius is troublesome. We do that, and we do not do that till we see that the child has enough balance to stand and walk. That's what we do. So we could have a child very poor balance, needs a lot of support, heel is off the ground. Here, the ankle is almost neutral. Remember, I said heel off the ground does not mean equinus. You look at the angle between the tibia and the foot. Very commonly, I see surgery being performed on such children because parents are worried the child is walking with the heel off the ground, and is walking with the heel off means heel has to come down. So for that, it's a very simple surgery. It takes you 10 minutes to do. You do a tendo-Achilles lengthening. That's an absolute disaster. You will end up with a child who's a walker, potential walker, to be a forever non-walker. Reversing that is very difficult. Now, this untreated, without bracing, without physiotherapy, without sometimes Botox. So when do I advise Botox? I, by and large, are very reserved in using Botox because, as I said the other day, the people that want to look younger will continue to use Botox, and the cost of Botox is not going to come down as long as there are such people. So Botox is a very limited, special situation where you have tried therapy, you have tried bracing, and yet the child is having, even with the ankle foot orthosis, walks with a severe equinus, and then you do a Botox, and the child is less than 5. Child less than 5, severe equinus, not getting corrected with therapy and with ankle foot orthosis, you would consider Botox as an indication. Again, remember, many people say, no, I'm afraid of complications, so I don't operate. Don't think leaving an equinus without surgery is without complication. Like this child, when you see this child, border below, it has become a convex like a rocker bottom foot. Why has that happened? Because the child has an associated flexion deformity. So if there is a child with equinus or a child without equinus but with a flexed knee, remember, over a period of time, as the child becomes older and becomes an adolescent, this child will have a stretching of the tendo-Achilles and will have a problem of over lengthening of the tendo-Achilles. And remember, the tendo-Achilles is your powerhouse for walking. And if the tendo-Achilles is overstretched, then the powerhouse is gone. And if your powerhouse is gone, you're changing without surgery, without so-called not doing any intervention and therefore not doing any harm, thinking like that, you might end up with a child having a disaster situation of a mid-foot break. We do not want that to happen in any child. So that is something that you have to remember. Do not allow a child with flexion deformity to grow older. Flexion deformity of the knee to grow older. And sorry, my battery went low. And have a mid-foot break coming up over a period of time. So please remember that this child has a frank midfoot break, and that is a difficult child. So remember, midfoot break happens as the child grows taller, as the child grows older, and as the child grows heavier. So here is a frank midfoot break, flex knee, equinus ankle, heel is off, midfoot break has happened. Correcting this is a real challenge. That's a real challenge. We do not want that to happen. You can see the rocker bottom that has come up. We don't want that to happen. Also, here is this child who has, because of severe flexion deformity, the tendo Achilles got overstretched. Very difficult to get this tendo Achilles. That's a calcaneus deformity of the ankle. You can't get that child. See this child. He's heavy. He's older. He's 18-year-old. Look at the ankle. It's gone into gross dorsiflexion and gauze abduction. This could have been prevented. This child should not be ending in this stage. The caregivers, whoever was the surgeon, the therapist, the neurologist, the pediatrician, failed to recognize the downside of such a situation in this child, and that had to be. Again, you should remember an equinus child walking on toes. Don't think rocker bottom is the only thing which can happen. Something else which can happen. The moment you have the heel off the ground, you have a hyperextension thrust coming on the knee. All children that are older walking on their toes will end up having a recurvatum knee. Recurvatum knee if there is no hamstring spasm. Sometimes even with hamstring spasm, they will have a recurvatum knee. So if your child is there coming to you, whatever be your level, therapist, neurologist, pediatrician, whoever, an orthopedic surgeon, if the child is having a recurvatum knee, check for ankle equinus. If there is equinus, you know that's trouble. That can lead to a recurvatum knee. So here is a patient, looks like equinus. Heel is off the ground. Is actually the child is having a dorsiflexion of the ankle. It's not equinus at all. It is just dorsiflexion. Sometimes you can make it out. See that it's an ankle in dorsiflexion, not an equinus, but heel is off the ground. You need to know the difference. You need to really see, is the foot plantar flex in relation to the tibia? And unless you know that and recognize that, you will cause a disaster. You sometimes, I always have a goniometer in my pocket. I always double check, is it truly 90 degrees? This child, just look at the child, has had surgery. Surgery thinking has got an equinus deformity. Child did not have an equinus deformity. Child developed a calcaneus deformity and a valgus deformity. This side is the calcaneus deformity. And a calcaneus deformity with a weak tendo Achilles. Tendo Achilles here is somewhat working, but it's not working here at all. That's a disaster for this child's walking ability. We do not want that to happen. Okay, so we need to remember that all these children, sorry, am I going back? I think I'm going back. Okay, so then there is a category of children, when you watch them walk, they walk with in-toeing. They walk with in-toeing, both toes going in. Now, rotational malalignment can be because of a rotational problem in the leg, in the thigh, in the hip, or all these components. So our job as surgeon is to assess what is the cause of this rotational alignment. How do you look at that? First, you look at the foot-thigh angle. Put the child prone, put the leg into 90 degrees, and look at the feet from the top. Normally, the angle between these should be around 15 degrees. That's the normal angle. If the foot is going out, it's very much externally rotated, then you know that it's the tibial torsion, that is extorsion. If the foot thigh angle is normal, yet the foot is going into in-toeing or pigeon-toed walking, very common complaint against the in children with cerebral palsy, you find this. Again, when the foot goes into external rotation, like the foot, the lever arm advantage of a normal foot, which is facing about 10 degrees or 15 degrees only, is reduced when this foot goes into external rotation. This lever arm gets markedly reduced. Dr. Dhiren Ganjwala, my friend, has given me this slide. Very clearly, the lever arm on the left side is longer. Lever arm on an externally rotated foot is much shorter. And that causes problem. This boy had come to me with a bent knee. And he was already advised the surgery for flexion deformity of the knee. When I examined him, he had no flexion deformity. And when I examined him for the angles that I checked for in assessing the knee function, I did not find the hamstrings were tight. What I found was that the foot-thigh angle was exaggerated. And the only surgery I did in him was a derotation osteotomy of the leg. Tibia was derotated to get to this position. And the child could now walk with a straight leg. No surgery for the knee deformity, no surgery for the foot, only surgery for correcting the extortion of the tibia to improve the lever arm advantage of the foot. There are children that come to you with severe flexion, hip, knee. They have rollator walking ability with equino, varus deformity. These children may need surgical intervention to do bony procedures. By and large, we reduce the bony procedures as far as possible. These are very low number of patients, and many of these children are GMFCs 4 and 5, bedridden. There you need to be very clear. Why do you want to? Do you want to improve the footwear or donning and doffing of clothes? You may do that. In a child, GMFCS5, I still remember the child had a severe flexion deformity of the knee, but he was wheelchairable. So the mother came to me, Dr. Saab, can you please reduce the bent part of the knee? I looked at the child, examined, looked all right to me, put him on a wheelchair. He could sit comfortably in a wheelchair, but with an beyond 90-degree flexion of the knee joint. So I told the mother, why do you want this? Sir, I sleep with him. When I sleep with him, his knee sticks and he keeps having repeated spasms of the knee in the night, and he keeps kicking me with the knee at my back. I never thought of that. So I did reduce the degree of flexion deformity in that child, though here the goal was different. Goal was not to get the child to walk. Goal was to make it comfortable for the caregiver of this child. So when you're looking at the knee, we do what is known as a static assessment. Is the knee straight on lying down? And when you do a straight leg raising test, does the knee flex? Normal straight leg raising in normal human should go up to 60 degrees. In these children, if it is coming to be less than 30, 40 degree, then it is a tight hamstring. Then we look at what is known as the popliteus angle. Popliteus angle is checked like this. You hold the patient, hip flex, knee flex 90 degrees, hip flex, knee flex, and then extend it. So when you do the first rapid movement, where the knee stops is the R1. Where the knee stops after some time, remember, spasticity is velocity dependent. When you do it rapidly, that's the first level of resistance. Then if you keep it on for some time, the next level of resistance comes. The difference between R1 and R2 tells you the degree of dynamic component of the deformity. So if you're examining a child for hamstring spasticity and you find that it is predominantly dynamic, then you can try, can you do physiotherapy? Also be because of a chronic walking on a bent knee, which causes overstretching of the ligamentum patellae, which causes the patella to ride high and causing a patella alta. So these are things that are the surgeon. Here, full extension is possible. See that? Though the child has got a hamstring tightness, the child is able to extend the knee fully. So we know that we do not have to worry about improving the extension leg. However, as I told, if it is coming to the hip and there is a severe scissoring, earlier we used to do total neurectomy of the hip joint. Today we don't do a total neurectomy of the hip joint. We do only a limited release only if there is a significant scissoring. By and large, the scissoring tendency gets better as the child grows older. However, a relentless spasm with severity of crossing over like this has to be differentiated from a less severe flexion deformity of the hip and knee, which may not need any intervention for that. By and large, we try to avoid neurectomies for doing this, except in a child where true scissoring, severe scissoring and crossing over is impeding the walking ability of this child. So this young girl came to me with a frank crossing over, with a frank W sitting. I did an adductor. I don't do a total release. Total release can cause an abductor posturing of the leg, which is very uncomfortable. I have patients coming to me with total neurectomy done, and total adductor release. They come with an abduction deformity with a broad base gait. Feet are wide apart. It looks very bad. And for the patient also, it's extremely uncomfortable. So you may need a partial neurectomy. In this done, a partial neurectomy of the anterior division. One branch was done along with one adductor longus muscle release. Child could suddenly walk with legs spread out and could even negotiate ramps. But today, the recommendation based on Swedish study is that if there is adduction deformity, adduction and internal rotation and scissoring in a child with GMFCS 4 and 5, please remember, do not forget to do annual hip screening. It's a standard recommendation based on Swedish registry studies of children with cerebral palsy. They have a severe tendency for hip dislocation, and we want to prevent a hip dislocation. And if a child has got a hip dislocation, it will reduce the walking potential of the child. A walking child may become a non-walker if you've forgotten to look at the tendency of the hip to dislocate, and we look at it by what is known as a Reimer's percentage migration. In a Reimer's percentage migration, if the hip joint is getting uncovered from the edge of the acetabulum more than 30%, that's a warning sign. You may need to do some intervention. So this child, older child, unremitting adductor spasm has led to a frank dislocation. This must be prevented. Do not allow this to happen. That's an important message that I have to give. Annual hip screening, especially for GMFCS 4 and 5, must be done in all these children to prevent a hip dislocation. This is a disaster for this child, can take away the walking potential of the child. Quickly going on to the upper limbs, one neglected area. The hand is the best creation of the creator in this world. It's a fascinating. It has three key functions: hook, like the hook function, hooking out a book from the shelf; grasp function, grasping a book like this; and then pinch function, like turning the pages of the book. Three key functions define all the functions that we do with our hand, the complex activity that we do with our hand, all the complex activities. These three key functions are compromised in a cerebral palsy child. Why? Because they have a pronated forearm, they have a palmar flex wrist, and they have a thumb in palm. They can't take the thumb out. The thumb is adducted and the fingers are clenched like that. So they can't do a hook, grasp, and pinch like a normal hand. So they can't do this grasp of a glass also. Activities of daily living is compromised. The other day, a patient came to me, Doc Saab, after surgery, Doc Saab, now he's constantly on the cell phone, because now he can hold the cell phone and he can use the cell phone touch screen. So we need to look at what is the functional limitation that the child has. What is your goal? Is your goal to do activities of daily living, of eating, of holding a glass, or holding a walker, and or even a crutch to walk? So are we looking at cosmesis or are we looking at function? Remember, despite the best efforts of the surgeon, a child with a flexed, pronated palmar flex wrist and having severe deformity may improve functionally, but when he is walking fast, the reflex tendency of the forearm to be flexed at the elbow, the palm to be flexed at the wrist, the forearm to be pronated, and this posturing. The parents, I have had girl children whom I have operated, and they said, Doc Saab, she's still walking like that. That hasn't improved. I said, okay, has she improved functionally? Yes, she has improved functionally. But cosmetically, she is not improved. So the goals have to be very clear. What is it that the child has? That at birth, you suspect cerebral palsy by thumb clutched hand. And over a period of time, with therapy, it opens out. You don't have to operate all of them. You have to look at them. And as they grow up, it will open up. And as they grow, the elbow flexion and pronation slowly also decrease. So we need to continue to maintain their stretchability by therapy. We do not like to do bracing. We encourage activities of daily living. We do not like to do bracing. We assess them clearly and we look at their range of movement, passive, active, dynamic, contractures. What is it that we look at? For example, the thumb, can it be abducted? Can it be extended? And one of the reasons we assess the hand is, even if you've done surgery and got the hand to be a more cosmetic position, the child may not use the hand. That's because of loss of stereognosis function in these children. So before the surgeon is taking, it's good for the therapist to assess the stereognosis in this child. Does the child have stereognosis? If yes, the child will use the post-operative hand. If the child does not have stereognosis, child will not use that post-operative hand. You have to be very clear on that. You need to define, is it a contracture? Is it a dynamic one? Or is it a fixed contracture? Is the child young or is the child older? We try to avoid splints because of splintage will restrict the development of the hand. Splintage will restrict the hand use. Splintage will prevent the child from having a stereognosis imagery of his hand and objects in his hand. So we try to avoid splints except in very special pre or post-op situation where we want to look at them and we want to improve their functioning. And several surgical interventions are described. When you look at that, we need to look at what is the pattern of hand that the child has come. Child's hand is abductable hand, but the pattern is the wrist is extension and full extension of the fingers, or is there a constant length phenomena? The wrist cannot be extended without flexing the fingers. So those have to be looked at. The surgeon can assess this carefully. And if you have a child who has got a flexed hand at the wrist with thumb clutched like that, you try to stretch the fingers out, it doesn't stretch out. That's because the forearm muscles have all tightened out. They've gone into contracture or dynamic spasm. Sometimes when you stretch the wrist out and open out the palm, it opens out. But sometimes when you palmar flex the wrist, the fingers open out. But when you dorsiflex, it goes into a flex position like that. So that's the constant length phenomena. We always assess this and see, is it stretchable, not stretchable? Is it a contracture? And if you fail to correct a persistent flexion of the wrist, you will end up with a swan neck phenomena. The swan neck phenomena must also be prevented, like you're preventing a dislocation hip. These children end up with poor function and can end up with contractures also. I'm not going to details of these because these are difficult areas. We do not like to correct the biceps contracture unless it is more than 90-degree flexion deformity. We try to see if we can manage with therapy. However, a pronation deformity of the forearm can be corrected by release of the pronated teres. That's called a Tubby's release. It can also be corrected doing a flexor carpi ulnaris transfer to the dorsum. From the volar side, deforming force, you take it to the dorsum. So we do procedures to improve those functions by surgical intervention. But remember, all these are done between the age group of 6 to 8 years. None of them are done when the child is younger. They need to be having the IQ, the cooperation ability to do post-op physiotherapy. So what do? Surgery is tendon transfers. A spastic deforming muscle like pronated teres is taken to correct the wrist flexion deformity. A spastic deforming force like flexor carpi ulnaris is taken to the extensor carpi radialis brevis. So you need to be familiar with these procedures, and sometimes when even under anesthesia, child hand is clutched like that, which means all the volar compartment muscles are contracted. Then you may need to do a myofascial lengthening of these. Very rarely you may do other bony procedures. By and large, we try to avoid that. An adductor spasm can be corrected by a myotomy or a Z-plasty like this, or you can stretch it out. If it is not working, you may need to release the muscles or the tendons to correct these kind of deformities. That's a type 2 Hauser classification for deformity. So I'm not going to details of that, but this is a cortical thumb, a severely flexed thumb with a flexor pollicis longus contracture. Now, this is a very difficult deformity to correct. This may need myofascial release of the flexor pollicis longus of the flexor muscles, and it may also need myotomy of the adductor muscle. So these are difficult procedures. This is under anesthesia. We are looking at this child. We can do a myofascial release here. This is more older classical procedure. This is actually a 25-year-old child. By and large, now we do it in the forearm. The same child can do a good, reasonable dorsiflexion, but not very much more. So here we do the flexor carpi ulnaris transfer to the dorsum, correct it, transfer it to the extensor muscles, and look at the post-op. See that? That same patient can extend her wrist nicely and extend her fingers also. It's a nicely functioning. The functional improvement is possible. So upper limb improvement is also possible in these cases. See the amount of dorsiflexion possible, and you can see the muscle sticking out here is contracting nicely. But remember, upper limb, lower limb, total assessment. Upper limb, lower limb with total assessment of the functional ability. JMFCS 1, 2, 3, 4, 5. What is your goal of treatment? Top goal is communication. Second goal for communication, education. After that, activities of daily living. Walking independently is the last priority in our goal. So the team has to decide as a team, what is it our priority? Primum non nocirum is what we take oath on. But primum non nocirum does not mean that if you don't operate, you will do no harm. If you don't operate a child with cerebral palsy needing surgery, you may do harm. You may also do harm by doing surgery. So decision making in cerebral palsy is very difficult. It is challenging. I never do it on one visit. I always do it on 2, 3 visits. So when I come see the child, I assess the child not once. I have the documentation done. Then the next time child comes, I don't look at that part. I don't look at the page. I tell my PG, don't show me that. I see the child again. If there's a difference between my first assessment and my second assessment, I hold back. I don't operate. I reevaluate and then see, can I do something else? Thank you very much. Am I there?
Just yeah, I think that was a lovely talk, and the initial introduction by Dr. Asha Chitnis was simply great, and thereafter the orthopedic guidance that Dr. Matthew Varghese gave. And request Dr. MKC Nair to put in his
Diptanshu, Dr. MKC logged out because of rains. He's just trying to get in back. He's been disconnecting repeatedly because of the rain there. So he's just going to join back. So Dr. Biju, it's all yours till he joins.
Till MKC Sergeant. Thank you. Thanks, Dr. Shafali. That was a fantastic masterclass from Dr. Matthew Varghese. I thoroughly enjoyed it.
Sorry, it's a 3-hour lecture, which I normally take. I didn't get time to edit my slides. Sorry, apologies for that.
It took me back to my medical.
Dr. Biju, MKC sir has joined. I don't know if he's transiently joined, then we'll let him speak if you don't
let
mind.
him speak. Yeah, no problem.
Dr. MKC sir, you can speak, sir, before you get logged out, sir, please, sir. MKC sir? Yeah, sir, please. Yeah.
I think it was a fantastic day one, but I could not hear the whole talk because of internet disturbance, heavy rain here. But the thing I liked most was, for the first time, I have some sore throat fever. I'm not well. For the first time, so much importance is given to physiotherapy, orthopedic management, and a collaborative approach of eminent people. So that has done a great, thing for improving the lot of the CP children, because we work in compartments. Neurologists will give their diagnosis. Orthopedician may hardly see these cases unless referred to them, and then the physiotherapists keep doing it. I think the lesson I learned from this first day session is that if only we work together, I think the lot of the CP children can be improved a lot. And the first talk had a lot of good points, particularly on talking on the thinking of the adolescent CP child from childhood itself, so that they can do better when they become adolescent. Thank you.
Thank you, sir.
The other talk I could not hear properly, so I'm not able to comment.
Sir, and thanks for joining. You have not been well
Okay,
for last
madam.
couple of days. Yeah, thank you so much, sir. Thanks. Dr. Biju.
Thank you.
Thank you. Thanks, MKC,
I'm not
sir.
well at all. Actually, I'm lying down.
Oh,
No,
yeah.
I know. Thank you, sir. So you can switch off the video and lie down and make comments lying on, sir. Thank you.
Thank you. Thanks, MKC. So I was just
Thanks, sir.
telling Dr. Matthew Verghese that it took me back to our college days, sir.
Yeah.
Like when we had clinics with Charian Thomas sir, and it was a fantastic masterclass. I'm sure AOCN will have it recorded online for people to watch. I think those who have not joined the talk has missed a lot. I mean, both Dr. Asha and Dr. Verghese sir highlighted the salient features in the management of CP and the key factors that it is a multidisciplinary management, and the focus should be on, as Dr. Verghese mentioned, the activities of daily living, which I would say activity and participation. But again, the key things is prevention, and that prevention, I think, as you rightly said, MKC sir, it starts from the antenatal period, increased maternity care, and then subsequently the early diagnosis of CP during the developmental stages. I know it's something which is very close to your heart, MKC sir. So, but the problem is the incidence of CP in the UK is, I think it's 1 in 400. So it comes to around 2 in 1,000. And that's the numbers which is being quoted for countries across the world. Perhaps in India, I think Asha mentioned 3 in 1,000, I think.
Yeah, it is 3 into
But
1,000.
the 3 in 1,000. But so despite all the advances in maternity care and the rest, the incidence of CP hasn't really changed, and which is a very, very disturbing fact. And even in our clinics, we still see children referred for the first time age 5 and above, which is again very, very disturbing. But the key things which have changed in the last 10 years, I think the hip surveillance has been very, very successful in Europe. And Sweden obviously has a very envious status on that. The cerebral palsy follow-up program in Sweden was started in '94, and prior to that, the hip dislocation was 9%, and I think it's practically nil now. I think it's 0.4 something. In the UK, since we had the cerebral palsy integrated pathway, the incidents have gone from around, I think it's from 9 to around 4.5 or something, but still hip dislocations are still a problem. The one question which I wanted to ask Dr. Matthew was about the current status of single event multi-level surgery in India, or is that something which is now practiced as a gold standard across the country, or is it still low to improve from that point of view?
There is a caveat on that. Surgeons that are experienced in single event multi-level surgeries are comfortable doing that, and it's convenient for the patient. However, if you're a beginner, I have had patients coming to me who have had so-called single event multi-level surgeries becoming non-walkers after surgery. Your assessment of the primary component and the secondary liver arm dysfunctions and the rotational liver arm dysfunctions have to be analyzed very carefully before arriving at that. That's number one caveat. they have found that when they do a systematic review of single-level and multi-level surgeries, the complication rates can be higher if the number of surgeries for cerebral palsy in that center is not that good, if it is not above a critical level. So if you're doing that, even there where it is critical, you can make mistakes. For example, in single-level, multi-level surgery, one of the components was to deal with the hip, knee, and the foot, and the rotational components of liver arm dysfunction simultaneously. That is what SCM similaris was all about. Subsequently, and the Japanese technique of doing over the brim myofascial release of the iliopsoas flexion component of the deformity of the hip was promoted. However, recent research work by a friend of mine, Dr. Reynold Brunner from Bern, has shown very clearly that doing a myofascial release of the iliopsoas is detrimental to the child. Detriment to the child. I did not talk about the gait analysis and the instrumented gait analysis detail. That's a completely different lecture on gait analysis for decision making in surgery for cerebral palsy. They found that when they do a myofascial release of the iliopsoas, then these children's ground clearance ability goes down. So the current, he has published that as a paper, and it has been published. When he was doing the research work, he discussed with me, what is your percentage of myofascial release of the hip joint? I said, I don't do it at all. Why don't you do it? I said, I do a kneeling balance assessment in these children. And when I do a kneeling balance, most of them are able to stand upright with their hip without flexion. So when you're doing the myofascial release, usually you're actually over relaxing the dynamic spasm secondary to a knee or an ankle problem. And therefore, the damage that is possible to the ground, for ground clearance, you need hip flexors and knee flexors. Knee flexors are already overactive, but the hip reflexor overactivity is secondary to a knee flexion. So if you do that in similaris, you can do more harm. So similaris, single-level, multi-level surgery, when you're clear about the indication, yes, it is good for the patient and the caregiver and for the therapist. But if you're not clear and you made a mistake, it can be a disaster.
And what's your approach in those children who have both compromised hips and curved spines? Do you have what's your approach on like what goes first? Do we tackle the spine first or the
spine kyphosis? Many of the parents come to me with the spine problem first. When you examine these children, these are children with severe spastic hamstrings, which tilts the pelvis backwards and contributes to a kyphosis. And when you get them to sit and stretch their leg out, they have a tripod posturing that is there. And that is usually secondary to a hamstring tightness, not a primary problem in the spine. Hemiplegics with spastic one side may have some degree of scoliosis, but I don't think that is a major issue in these children. Scoliosis and kyphoscoliosis as a problem of neuromuscular scoliosis is more problematic in children with dystrophies, children with dystonias, children with other neuromuscular conditions, and less often with cerebral palsy children. But in cerebral palsy children, most dominant problem is kyphosis from severe pelvic tilt, from severe spastic hamstrings.
Thank you. And in our setup, normally, if there is significant pelvic obliquity, then sometimes the spinal surgeons want to operate first, but then we'll make sure the screws are left short enough for if there is a subsequent pelvic and osteotomy. So lots of discussions usually happens around that.
So I try to deal with the hip, pelvis, hamstring dysfunction first.
Thank you. While MKC sir is online, sir, in terms of early diagnosis of these children, What's the current status in the screening in India, specifically in Kerala?
Yeah, the point is every baby born in a hospital, major hospital, is followed by a simple on head holding at 4 months and standing at 1 year. So the mother becomes the early detection person. And this has been a great success, at least in SAT hospital with 20,000 deliveries. And we are doing it in many other hospitals. Number two is when you have a problem with head holding or sitting, standing, we have a grading, and that grading will immediately tell the pediatrician that there is a problem. And the grading is very simple. For example, sitting grading, the 2 will be sitting forward, 3 will be sitting straight, and 4 will be turning around. Simple things any pediatrician can do. If you do that, I want to say this, there's something called simple things done for millions of children will bring more results than a very sophisticated surgery for 10 children. You get the message? So that's the second point. Third one is we have cleared now the national RBSK has come, Rashtriya Bal Swasthya Karyakram, and there we have the district early intervention centers. I just 3 weeks ago, a month ago, I published 2 books, one on habilitation, the other one on rehabilitation. Now, the separating habilitation from rehabilitation is the most important point.
I think we lost Sir there.
Yeah.
Mm.
And actually, Dr. Biju,
To prevent
it's
CP,
come.
because the problem is not going to go away. Babies are surviving things. So what do we mean by that? We need to really go for that. That doesn't mean a single sitting surgery, all that are not good. All that are important. But the majority, the mother can do the monitor, then the health workers can do, the pediatrician can do. And most important, in the newborn period, first 1 year, you only need to look for hypotonia. Do you have increased tone? Do the early stimulation by the mother. And we have proved that it will be effective. Now, suppose at 1 year, the hypotonia persists, then it becomes persistent hypotonia. That is the early marker of CP. Except in very, very few children, even at 6 weeks, you may have classical CP. That is a very, very rare situation. But otherwise, majority of children, the students should be taught to look for hypertonia, and most important is the adductor angle. You separate a leg, you can't separate, it is a problem. So whether it's a hypotonia, tone abnormality, or whether it's a dystonia or abnormal movements, that they need to know how to separate. So by that, you will be able to do that. Then, of course, the technical part comes. I said that till here, what I talked was very simple thing. Any MBBS doctor, any nurse, anybody can do. After that, of course, things become little more. After 1 year, classical cerebral palsy comes. And one more thing, I think we have not given enough importance to global development delay. Now, if you can look for global development delay and try to investigate, I'm sure it's very difficult to investigate at the early ages, but if you can investigate, then very soon you will be finding some neurometabolic problems which takes its own time to emerge. So that will be also one. So that's what, again, I'm talking about CP mimics. It's not a classical CP. One more point I will say, the best thing that I found was useful was an ultrasound at the time of discharge, because a ventricular white matter damage or any abnormality which can be easily picked up by a good ultrasound, not MRI, will be the best indicator of a cerebral palsy later on, particularly the diplegic type. So that will be the message. That's what we do. This is the message that we are doing. One word about DIC. One of the problem with the DIC, we just finished training of DIC staff, whole of Kerala. And I sat with them for 2 days each. What I learned is that many of the therapists are trained in adult therapy, they are not so comfortable with pediatric patient, particularly when it becomes smaller. So I think we are in a path to really do the training for them. And second part is, I heard somebody saying it, mother, the best therapist. I believe that. You should not do therapy in a closed room. You should teach the mother, because you are spending 40 minutes. Mother has 16 hours a day for the baby. So if we can do mother do it, that is the best thing. And second thing, we should work together.
Yes.
Because never, all my life, even if I know the diagnosis, the patient is so happy with me, I will say, show to my pediatric neurologist. It's a fantastic relation you should develop with them. Because sometimes a rare thing he may pick up or she may pick up, which is important. And also discuss with your therapist. Don't think they don't know something like that. They know enough. They know enough. They have a lot of experience. So from them, the doctors also can learn a lot. So my book on rehabilitation therapy is a evidence-based analysis of what all these therapies are. It's a respect the therapists as individuals on their own right, but at the same time, learn that all therapists work together under a developmental pediatrician or a pediatric neurologist to give that little last 5% medical input. Okay, that will be my vision of how we should tackle CP. Of course, as they become bigger, then the problems differ. You need rehabilitation person, you need a lot more things. Thank you.
Thank you. Thanks, MK Cesar. Thank you.
Thank
Yeah,
you.
just to reiterate, that's very important what MK Cesar said. Like, we often say, like, when we think about cerebral palsy, we think it as a movement disorder. But the incidence of children who can't walk is around like 60%. We say one in 3 is unable to walk, but 1 in 2 has an intellectual difficulty. So the developmental delay is quite important. And the other thing, as Dr. Matthew has highlighted, the pain, 3 in 4 experience pain, and it has to be addressed. Very, very important.
I think any questions, Diptanshu? Can you just speak up the questions before we ask one final messages? Yeah.
I'll move on to the questions. We have a couple of questions. How frequently should physiotherapy be done by caregivers each day?
It's not about how frequently the therapy should be done by caregivers. If you really look at their home setup and how they're doing and put it into their daily practices and give them functional guidelines, I think so it just becomes a therapy and less burden to the parents. Rather than saying do this and do that, just does not work. What that child needs for that time, and even if she's eating, dressing, bathing, playing, I mean, therapy is done. That's how you need to do. So the burden on a parent is so much less.
Absolutely. And there's another question. Does the statement GMFCS level not change over time hold good both for spastic and dyskinetic CP?
All cerebral palsy. This is only for kids with cerebral palsy. Any, absent, across. That's why it said that anything, it's not tone related. It's GMFCS related. And that's most important.
And it's very unlikely, very unusual for a GMFCS to get better. Sometimes you can sometimes between 2 and 3, you sometimes think whether it's a 2 or a 3. But I've never seen a 4 become a 3 or a 5 become a 4. On the other way around might happen.
Yes, correct. 3 can become a 4 very easily. That 3 is someone where you really need to be careful. 1 and 2 are fine. 4 and 5 will never change. But 3 can suddenly become a 4.
Role of muscle relaxants like baclofen in second year of spastic CP during physiotherapy.
I think so. See, I have no right to speak on the role of medications, but I'm just going to see as a therapist, pick up the phone and talk to my neurologist. If any medications gives my trunk control a downward, which is something that keeps me going, I would ask her to titrate. But I mean, remember, we as therapists never treat tone. Tone is treated by you all when you give medicines. We just develop control. So I think so. It depends on who the child is, what he requires, and what you're really working for at that given point of time.
Okay. There's another question. Does glycopyrrolate help in ruling CP child?
Diptanshu, Dr. Biju is going to tell about
baclofen. Just to add to what Dr. Asha said, baclofen is a muscle relaxant. It, as you know, it works in the postsynaptic GABA B receptor in the spine. But what we have to be aware is it has got a very low therapeutic window for adverse effects. And we should not try and make life difficult for the therapist and also for the child. We have to be very cautious and about the judicious use of baclofen. And I'm sure perioperatively, I'm sure Dr. Matthew might use to tackle spasms, etc. But of the side effects, the one which you have to be aware of is exactly what Dr. Asha said. The loss of truncal tone with baclofen is very key. And so using it willy-nilly as a muscle relaxant would be a bad idea.
And what about
can I just add here? Can I just add
yes,
here?
sir.
Yes, I use it only very infrequently for painful muscle spasm. One has to remember painful muscle spasm. I might try it out. However, one has to be sure truly a spasm from excessive spasticity and not a painful spasm secondary to a musculoskeletal problem, which is very frequent. I have patients coming to me. Parents say, sir, he used to walk till 6 months back. Now he stopped walking. It's so painful to get him to stand. So my first thought is it spasm? There is spasm, yes. But should I give baclofen? I think about it. Then what do? I was naive initially when I saw some of these patients early on, about 15 years back. Now I know the reason. Many of them were homebound, bedridden. They don't get out. Many of them are anticonvulsants. They have hyper metabolism of the vitamin D from the anticonvulsants, and they do not go out. And even if they go out in the sun because of pollution, the 350 nanometer required for converting the ergocalcerol into cholecalcerol is not happening because it is not reaching the ground level because of pollution. So these children are deficient in vitamin D and calcium. Again, mistakes that surgeons and physicians make is vitamin D is low, calcium is normal, give only vitamin D. No, calcium is normal because it is being taken from your skeletal system because that is your reservoir for calcium. And calcium as an element in the blood is maintained at any cost. So to get to a low level of calcium, you have to have real bad long-term deficiency which causes problem, and by the time they come to you they have muscle weakness, proximal muscle weakness because of severe vitamin D calcium deficiency, and bone pains because of severe calcium depletion from their bones. So beware, giving baclofen to such a child because of spasm from pain can be catastrophic again. So find out why the child is having severe spasticity. Is there any nociceptive stimulus that is contributing to the spasm? Address the stimulus and don't give blindly baclofen.
Excellent. And would you like to comment on glycopyrrolate?
I don't use glycopyrrolate. I don't use anything for the drooling. I reassure the parents. Why is the child drooling? Child is drooling because swallowing reflex is poor. So as the child grows older and learns to swallow, encourage swallowing reflex so that they can swallow the thing, and the parents can take care of nursing care by regular wiping away, number one. Number two, encouraging swallowing reflexes. I do not give any drug therapy because glycopyrrolate can have anticholinergic side effects, dryness of mouth, and all kinds of things are a problem. So whatever little swallowing the child can do will become more difficult. Mouth has now become dry. So I do not use glycopyrrolate. The Botox as an injection came up in the early part of 2000 as a therapy for reducing the sialorrhea and the drooling which was there. I have never used it. I don't know if anybody has skills. Yes, but I only guide my parents on the recommendation of teaching them swallowing and basic caring for the drooling that is happening by wiping it off. Nothing more. And
I
as they have grown older, they have all outgrown the drooling tendency.
I think when we are discussing of early detection, can Shefali talk about the England tool which she has modified, AIMS modified tool which can pick up CP
Yeah.
and NMD?
Yeah, I'll
Shefali?
mention, sir. I'll do that, sir. I think Asha was telling about drooling. I'll tell after that. Asha was talking about the exercise, oromotor. I think she was
think
going to
so.
say about that. Right?
Looking at oromotor exercise is number one. Understanding the EDAG. There are some kids who will drool. They're not something that they're going to stop drooling. See, your drooling is not only coming from swallowing, it's also coming from your proximal control. If a child whose GMFC is 4 and 5 is not going to have head control and trunk control, that child will drool. I mean, you have to accept that. I don't think so. There is a really role of medication. What Varghese sir said is so true. It has a lot of side effects also. But work the best that you can, teach the parent what is the best position. I think so positioning a child when the child is drooling is much more important than giving medications. Teach some basic things, how to hold, how to teach, how to draw. There are lots of, bottles that are available that if you can sit, teach them how it is. So that's more important than giving any medications.
Dr. Biju, your side of the high resource
So
drooling.
yeah, we use in the small number of children. We use sometimes like when there is a more of a mixed spastic dystonic or dyskinetic, we sometimes tend to use trihexyphenidyl, which may also have the added advantage of slightly reducing the secretions. Glycopyrronium is available as an oral medication. There's a small number of children who do take it, but you have to be aware of these the cholinergic side effects. Particularly, some of them might be obvious, like if they come back with the agitation, etc., or worsening constipation, but some we may not realize, particularly children who are visually impaired. Sometimes the cholinergic effects can be quite distressing for them. Same thing with trihexyphenidyl. Some colleagues use ipratropium bromide nebulizers or inhalers. I mean, mostly it is for the social acceptance reasons in terms of children who drool much. But like you said, like Dr. Matthew said, if you can survive with few bips a day, it doesn't really matter much. But for those children who have got really troublesome drooling, sometimes we do Botox, but again, we haven't found it very effective in general, and also sometimes it can compromise the swallow function because of the leak. Which can be a problem. And I know at least one child in our practice who had irreversible swallow dysfunction, who ended up with gastrostomy after Botox for salivary glands. But I don't think most of the time the swallow dysfunction is reversible. And then in the worst case scenario, we often reach out to our ENT colleagues, who sometimes do the gland excision or sometimes do a duct ligation. But duct ligation sometimes can be undone and it becomes a problem again. But sometimes they remove the submandibular glands. So there are several options available, but again, it is mostly for social reasons. Other than that, I don't see any other reason for using. The other thing is hyoscine patch as well, instead of glycopyrronium. Yeah.
Actually, that is true, and so we can have some drooling scarves for them. And although they, in couple of patients, they have done Botox hair. A couple of years back, we had one MS ENT dissertation during the MS thing on submandibular duct ligation. So in couple of patients, that time it was done, but it is not being done as a routine. And as MKC sir was pointing out, sir, it is very important to pick them up early. And as we have to do both. It's a pyramid we are working at, but we have to go to the masses. So we have to have the base of pyramid being expanded and going to the periphery and to empower the primary care physicians. So basically a child, so what we are basically have to do is follow up of high risk newborns. which has to be done from the SNCUs on there, and the ASHA workers are there, and the DEC, the Rashtrabal Swasthya Karyakram has, used the Inclin tool, which was developed as a screening tool as a ASHA level, and by the mobile health unit team, they see the screening tool they are using, but at the DIC they were using the Inclin tool to identify neuromotor impairments. That tool was for NMI, because neuromotor impairment was coined for having all the cerebral palsy, neuromuscular disorder, post-stroke, and post-meningoencephalitic sequelae. So that Inclin tool was 2 to 9 years, but then we had AIMS modified version. We had modified and focused on the areas which were missing, poorly done in the original one, like the dyskinetic were not being picked up early. And then we have this for 1 month to 18 years. This is a tool which is an AIMS modified Inclin tool for neuromotor impairments, addressing from post-neonatal period to 18 years. And that has some questions, and they have some, some things for examination, and they are published in Frontiers in Public Health, and they are part of other tools on a mobile app. Is so it's not the name is PED Neuro AIMS Diagnostics. PED Neuro NEURO AIMS Diagnostics. It's got it's a app available on Google and Apple Play Store, both the platforms, the Google and iOS platforms, and you have both the autism tool, the ADHD tool, neuromotor impairment, and epilepsy tool. So that is basically we're trying to encourage for point of care physicians, so that the primary care physicians who are seeing can handle these patients. But sir, trying to pick them up early, as you said, there were subtle things which the mothers can see, certain things the health worker can see, and certain things the pediatricians can see. So now actually there has been a lot of work being done on general movements, and general movements have been coming up in a big way, and there have been studies which are showing that the general movements at 5 months can be predict autism and CP, and but then you need the videos to be made. So currently we are doing a DM dissertation in which we are going to have a home-based videos which the parents will be clicking. We make the protocol and giving them a video of how to click a video and comparing with the in-hospital video and how to interpret that, and if that works, so in that case then we can have a platform in which people can be shooting their own patients' children's videos, and we can ask for a follow up in a centralized way in which maybe we can help prediction, because of those fidgety movements and all which have been seen. They have had quite good prognostic markers for CP, yes, and even for autism. So that is why we were trying to work in this area. So that would be something very good. Yes, but there'll be some subtle things. But I wanted to add one thing. Dr. Biju, you mentioned that things started from the pregnant mothers, but I must say that things start from adolescent girls, because their nutrition and their anemia and their immunization with rubella would be very important, because Indian, they get married, they're not sure about the things. So adolescent health will ultimately lead to the future mothers, and and then you don't have planned pregnancies most of the time, so giving of those the folate and all which has been done. So you have to have those things, and the first 1,000 days of a child's life, including the pregnancy time, is yes the most crucial. Yes, but the thing is we have to look at both the primary, secondary, and tertiary prevention. Yes, and primary, and as very rightly MKC sir said, so we do have CP mimics. So first of our seminars, the webinars was on CP mimics, and we had 6 CP mimics in wonderful cases from across India, which were presented by 6 people from 6 different institutes. So I think that is very important, and something of concern, as Dr. Bijum pointed out, that the incidence is not changed practically that much despite advanced care, and you do have an that N which is persisting in the high income countries where you have pretty resources. So I think we are missing somewhere something. I don't know. I mean, we'll have to just look at it. I would request final take-home messages from the speakers first, and then the experts. So, Dr. Asha, your final take-home message. I know we are past, our time by 26 minutes, and but we'll have final message from all. So Asha, Dr. Varghese, MKC sir, Biju, and Diptanshu should have the final verdict, being the moderator official.
Well, what I have to say is therapy is a limited resource, and parents are the biggest therapists who really are very important, and we need to empower them.
I think we need to provide them support and coping strategies. That is very important. And coping in the beginning itself, I think counseling of the parents, we don't have counselors. We don't have counselors in India. So I think every pediatric neurologist or the pediatrician or a development pediatrician, whoever is looking at the child, has to ensure two things. One is that you are going to be, guiding and the family, giving a full counseling session. And second is seeing the child holistically, because there's so many issues which are there. We have flagged only the two things. Rest will come in the session next week. So we will have, because thinking that therapy and orthopedics are two very major chunks, so they were kept separately, and because they get diluted when you're doing a panel discussion. So I thought that would, that's what when we were discussing the SIG team, we were discussing. So I thought that these two should be signaled out, and that will be important. And the another thing is that we should not only say the mother is the best therapist, we should say parents all the time, because it's a dumping always on the moms. Sorry, Asha, I know you.
Yeah.
So I think we should always say the parents would be very important, or primary caregivers, because you may have sometimes 10% you may have grandparents supporting it. Otherwise, yeah. Sorry about because I had my autism clinic and I was counseling them, so I was in that mood. Yes, Dr. Matthews.
Yeah, I think surgical decision making in cerebral palsy can be really challenging, but can be a life changer for the child. However, decision making has to be done very carefully, and it should be part of a clear goal setting with the therapist, with the parents, and the surgeon, because the goals have to converge. If there are different goals for each of these stakeholders, then you're in trouble. Your goals have to merge. What is it that the parents want? What is it the surgeon is expecting? And what is the therapist can deliver? They all have to converge. Only then the best results can come up. Surgery can be a game changer, but preferably chosen well. And we desist from doing any surgical intervention before the child is 5 to 6 years. Don't let a child grow older and older with deformities. Then they are more challenging to correct.
Thank you, sir. Actually, for autism, we have made a chart in which we have made parents' expectations, the pediatric neurologist expectation, and the therapist expectations, and then short-term, intermediate, and long-term goals. And we at least tell the parents that you should have that ready and go to all the therapists you have, so that the goals are common. All the short-term, the mid, intermediate, and the long-term. It's very important, because we don't have, like if you go to CHOP, you have one, and must be in GOSH also, that you have one floor, everybody is sitting, all the disciplines are sitting together, and one person has a CP appointment day, goes through all of them. We don't have like that. It's not possible. We've not been able to do a boardroom type. I have struggled and tried to do for neuromuscular disorders as well as this. It's not been there. So at least if they are sitting separately, for the same patient, they should converge on the same document. So, they should be working together, at least, in the documentation, and have the same thoughts and processes. MKC, sir.
Yeah, the only parting message I would like to say is you focus on the bio, psycho, socio-spiritual approach. We are all very good in the biological part. Psychological, we are very far behind. The social aspect and the spiritual aspect. One practical way of doing it is do a SWOT analysis of the family. Strength, weakness, opportunities, and challenges of the family. That is something I do. Every child we do that. And the moment you do the SWOT analysis, you realize that all the biological highest stuff you picked up from Lancet and all that makes no meaning to the poor parent. You get me? You do all the topmost interventions and all that, but it doesn't make any difference that particular family. So you come to simpler things which they can afford, which they can do by themselves. And what I like best in this today's meeting was Madam telling that mother or parent should be the main therapist. Thank you.
Thank you, sir. Dr. Biju.
Thank you. think all the three colleagues have nicely summarized it. So, I mean, I think as clinicians, you know, our overall aim should be to deliver this high quality, integrated, multidisciplinary care to children and adolescents with disability, and that should be in a very timely manner. That should be child and family centered. The care should be provided as near as possible to home, and the aim should be to reduce the disability, to improve function, quality of life, participation, and reduce the stress and the burden on the family and carers. Thank you.
Thank you. Raju, you have worked a lot. You wrote a book. Yeah, somebody, Dipanshu, he wrote a book also on CP. I thought, Raju.
Yes, madam. Good evening to all.
Yeah, he's still in his clinic. He's still in his clinic, you know.
So the main point is multidisciplinary care is very important, and especially it should be coordination between each specialty, because there not be any confusion between one specialty versus other specialty, because it causes a lot of confusion for the parents also. So it should be a lot of coordination should be there. That is the main reason.
Yeah, and Prashant, you are doing so much on the distant outreach areas. Anything you want to add?
Yeah, ma'am. Dr. Asha has correctly said, mother is the best therapist, and that's where in a rural part we are working on that.
Prashant, I said parents are the best therapist. Okay, modify your
Yes.
statement.
Yes,
Yeah.
ma'am. Parents are the best therapist.
Yeah.
Yes.
Yeah. Thanks. Diptanshu.
I think it was a lovely session and eye-opening one. All the
Your message.
sisters-
No, you give your message, na. You give your message first.
Okay. I think the early pickup is very important, and the role of clinicians in helping the parents taking it up is important. It's very important to empower the parents, and the biopsychosocial approach. This is very important. Something we unfortunately as doctors do not do enough about. So our role comes in as empowerers to the families. They are in a distress with their child, and they are worried about the disabilities. But if we work on the impairment, not letting them go into disabilities, there's so much that can be done. And definitely a interdisciplinary approach is needed rather than a multidisciplinary approach, which is there in most places. And as already discussed, mentioned again and again, it's the parents whose role is vital in the entire program.
Yeah, thanks. Ekta, you want to say you've switched on your camera? Want to say something?
I don't mind saying if you give me a stage
Yeah.
ever.
Please.
I just wanted to say that each child with special need creates a special family. So that biosocial, psychosocial aspect centers not to the child alone, but to the entire family, because every child with special need creates special needs for that family. So it's not just the rehabilitation of the child, it's the family which needs the family-centered approach, which is important, because they also need to adapt their life as per the child. There's so much expectations which a parent has before the child is born, and once they get to know that the child is TP, the entire family has special needs.
Yeah. Thank you so much. And I think it's very important to understand that a medical condition is there, but the disability is caused by the environment, which is actually not only the physical environment around, but the attitude of the people around. So I think looking at, we lack the humanistic touch in India. We have so much of stigma. So we need to expunge the stigma and have some humanism coming up. I'm really grateful to all of you on behalf of Mahesh, who actually winds up every time because he's traveling. So I'm doing his job. Really grateful to you all. And Dr. Matthew Verghese sir, Smita will blur the images of the children before the video is uploaded, so that it's not identified. But we have all the series, sir, and I think we are really grateful to have you all. And I mean, it was really amazing. And thank you, MKC sir, for joining despite you not being well. And thank you, Dr. Biju, for always being a support every time. And thanks, Asha. You're always amazing. And Dr.
Can I
Verghese,
say-
I'm really grateful. Yes, sir.
Can I say hi
Yes, sir.
to Biju, Amit? Can I say hi to Biju from
Yes,
TISAV alumni?
Yes,
We are
sir.
proud alumni of Trivandrum. So I just
Thank
Sir,
want-
you.
ye
My
Kerala,
voice is
sir,
bad.
Kerala.
No, I was
Sir,
actually, it
Kerala,
actually,
Kerala.
the moment I saw him, it took me back to the my child development lessons. Like the first lessons were from him only. This is like
Yeah.
30 years ago.
Yeah, yeah. Okay.
Thank you so much.
Yeah,
Bye.
Thank you,
See you
everybody.
next week.
A
Next
great
part
meeting.
2 of this part. Yeah. Thank you so much.
Bye.
Same day,
Thanks.
same time.
Bye.
Thank you.
Next
Same
same
time.
day, same time. Same day, same time, sir. It'll be all Wednesdays. Yeah. 8 to 9:30. We crossed the limit this time for half an hour actually. Thank you so much.
Good night.
Bye.
Bye.
Yeah,
Thank
good
you,
night. Good
everybody.
night.
Thank you.
Bye.
Bye-bye.
Bye.
You
Bye.
too.
Bye.